Welcome to the Deep Dive. Today, we're embarking on a really crucial journey, one that's custom-tailored just for you. We're doing a deep dive into understanding mental distress, our mission. Cut through the noise, look at the sources you've given us, and pull out those key insights, how to spot the signs, how to tell the difference between just a bad day and something more serious. And we'll look at systematic ways to help, plus the vital ethical stuff involved. Think of it as your shortcut to being genuinely clued in on a topic that, well, it touches all of us.
It really does. It's a topic that truly underpins overall well-being, For ourselves, for the people we care about, it can feel complex, this landscape, but the insights we're about to explore are, I think, profoundly important. They offer a clearer lens, really, for understanding and support.
Okay, well, let's dive right in then. Mental health. It's just as essential as physical health, right? Shapes how we think, feel, act. But for someone who isn't a clinician, how does mental distress actually show up? What are those general initial red flags we should be looking out for?
That's absolutely the right place to start. Often, the first subtle shifts, they appear as a persistent change in someone's emotional state. We're talking about things like excessive worrying, maybe, or a sadness that just doesn't seem to lift. It lingers for weeks, not just a day or two. You might notice someone struggling with confused thinking or real difficulty concentrating on tasks they used to handle fine. Dramatic mood swings are another big one. Not just feeling a bit up or down, but these extreme highs.
Yeah.
Maybe uncontrollably energetic or irritable, or deep lows that feel, well, inescapable.
And it's not just purely emotional, is it? It can impact their actual daily life in very tangible ways.
Oh, absolutely. You might see a growing inability to handle everyday activities. Maybe problems seem overwhelming. Social withdrawal is common, too, often quite quiet. Someone who used to be engaged suddenly just spending much more time alone. Noticeable changes in self-care, like maybe neglecting personal hygiene. Or an increase in substance misuse. Those are critical signs. And perhaps surprisingly, it can often manifest as unexplained physical ailments. Things like chronic headaches, stomach aches, other body pains that just don't have a clear medical cause. For younger kids, these signs might look different. Maybe changes in school performance, frequent temper tantrums that are really out of character, or this intense, persistent worry about seemingly small things. The key insight here isn't just spotting one sign in isolation, but seeing a cluster of changes that stick around.
That's where it gets really insightful, I think, because while those are general signals, different conditions, they have their own unique fingerprints, don't they? How do these more specific indicators help us really differentiate what might be going on?
Exactly. The specifics are where the real insight often lies. Take stress, for example. Everyone experiences stress, we know that. But chronic stress often shows up differently, like persistent irritability, maybe profound fatigue, a mind that feels like it's constantly racing, making thoughts feel disorganized. Physiologically, it's like your body's alarm system is sort of stuck on high alert, screaming danger, even when there isn't one, keeps you in that fight, flight, or freeze mode.
Right, that constant tension.
Yeah. Now, with depression, the key insight isn't just feeling sad. It's often more like a pervasive feeling of emptiness. Or even more profoundly, a loss of pleasure in anything. Clinicians call it anhedonia.
Anhedonia?
Yeah. Imagine your favorite food just tastes like nothing. Or a beautiful sunset just doesn't spark any joy at all. That absence of pleasure lasting for at least 2 weeks, maybe coupled with poor concentration, excessive guilt, feelings of hopelessness, or even, tragically, thoughts about ending one's life. Those are crucial markers. Behaviorally, you might see profound lack of energy, just total exhaustion, or even self-harming behaviors.
That's a very different picture than just feeling blue.
Very different.
Yeah.
Then you have bipolar disorders. These are characterized by dramatic, almost roller coaster shifts in mood, energy, and thinking. During what's called a manic episode, someone might feel persistently elevated, almost euphoric, boundless energy, a drastically decreased need for sleep.
So hardly slipping, but full of energy.
Exactly. They might talk incredibly fast, a mile a minute. Their thoughts racing so quickly, it's like they're trying to keep up with a speeding train. This can lead to inflated self-esteem, really poor judgment, impulsive, sometimes reckless behaviors, excessive spending, risky decisions. Their thoughts might jump rapidly from one unrelated topic to another, sometimes called flight of ideas. It makes conversation really hard to follow.
Okay. And anxiety disorders, we hear that term a lot.
We do. Anxiety disorders involve a persistent sense of apprehension or dread, usually from a perceived threat, real or not. You'll often see restlessness, irritability, maybe those subtle tension-relieving behaviors like constant foot tapping or fidgeting. Physically, the heart might race, breathing quickens, and there's often this pervasive sense of impending doom, just waiting for something bad to happen. And then there are panic attacks. These are like a sudden, overwhelming wave of intense fear.
Like out of nowhere.
Often, yeah. It can feel like a heart attack, palpitations, sweating, trembling, a terrifying sensation of choking or shortness of breath. The person might genuinely fear they're losing control or even dying. It's incredibly intense.
Wow. Okay. What about psychosis or schizophrenia? That sounds quite different again.
It is. In psychosis and schizophrenia, the most striking aspect is really a break from shared reality. Thoughts and perceptions are disturbed. This can involve delusions. These are deeply held false beliefs that aren't based in reality, like believing they're being spied on or that they have special powers.
Yeah.
Or hallucinations, seeing, hearing, sometimes feeling things that aren't actually there.
Hearing voices is a common one people know.
Yes, auditory hallucinations are common. Their speech can also become highly disorganized. Sometimes it's called word salad, just a jumble of unrelated words, or clang associations, where words are linked by sound rather than meaning, like, I see the bee, it's free, on the tree. And a really profound and challenging symptom is something called anosognosia.
Anosognosia.
Yeah, it's the inability to recognize that one is ill. It's not denial, it's neurological. It prevents the person from even realizing their perceptions are distorted, which, as you can imagine, makes it incredibly difficult to get them help.
I can see that. And personality disorders. You mentioned borderline personality disorder specifically.
Right. With personality disorders, particularly borderline personality disorder, BPD, the pattern is one of enduring instability. Across emotions, relationships, self-image, you might see intense feelings of emptiness, extreme mood shifts like going from idealizing someone to completely devaluing them in a heartbeat. Impulsive behaviors are common too: reckless driving, binge eating, substance use. Self-mutilation and suicidal behaviors are sadly quite prevalent, often driven by intense feelings of abandonment or overwhelming anger. Relationships tend to be very intense and unstable.
Okay. And eating disorders.
Eating disorders are fundamentally about a distorted body image and relationship with food. Anorexia nervosa is marked by severe restriction of food intake, leading to extreme thinness, but also an intense, irrational fear of gaining weight, even when dangerously underweight. Bulimia nervosa involves recurrent episodes of binge eating, consuming a large amount of food very quickly, feeling out of control, followed by attempts to compensate.
Compensate how?
Through behaviors like self-induced vomiting, excessive laxative use, fasting, or excessive exercise to try and prevent weight gain.
Right. And finally, substance use disorders.
Yes, substance use disorders, or SUDs. The signs of intoxication vary hugely depending on the substance, obviously. From the unsteady gait and slurred speech with alcohol, to extreme agitation and high body temperature with stimulants like methamphetamine. Withdrawal symptoms are just as diverse. They can range from anxiety and tremors to severe seizures or a dangerous state called delirium tremens, or DTs, often with alcohol withdrawal. The key insight here isn't just spotting drug use, but recognizing when it's actively impairing someone's life, their health, their functioning.
That's a huge range of distinct indicators.
Yeah.
Okay, so what does this all mean for you when you're observing these things? How do we really draw the line? How do we know if it's just, a rough patch or if someone is genuinely struggling with something more profound, more serious?
Yeah, that really is the million-dollar question, isn't it? And I think the best way to understand it is by thinking about a mental health continuum. Imagine it like a sliding scale. At one end, you've got well-being. Discomfort from everyday stress is manageable. Daily functioning isn't really impaired. We all fluctuate here. These are your rough days, those subtle, normal shifts.
Okay, that's one end.
Then, as distress increases, we move into the zone of emotional problems or concerns. Here, the discomfort becomes more pronounced, maybe mild insomnia, difficulty concentrating, appetite changes that stick around. There's a temporary, usually mild impairment in daily functioning, but often, with support, it can resolve. This is where those subtle changes become noticeable concerns, something to maybe keep an eye on.
Got it. And the other end of the scale.
Finally, at the far end, we have mental illness. This is when the distress becomes significant. It causes moderate to severe impairment in daily functioning at work, school, home. And when we talk about serious mental illness, we specifically mean a disabling functional impairment, something that profoundly interferes with major life activities. This truly represents a significant, often undeniable shift from how the person usually functions.
That continuum idea is helpful. It's like a weather report for your inner world, maybe. Sometimes it's just a drizzle, sometimes it's a full-blown storm, and sometimes that storm can escalate pretty quickly, can it? Can you describe how that progression might look when someone is moving into a crisis?
That weather report analogy is actually spot on. The sources we looked at highlight 4 phases of crisis development. It paints a clear picture of that escalation. Phase 1 is normal stress and anxiety. Someone encounters a stressor. They might feel anxious, sure, but they're still rational, generally in control. They're trying to solve the problem using their usual coping skills.
Okay, like a cloudy sky, but manageable.
Exactly. Phase 2 is a rising anxiety level. This is when those usual problem-solving techniques start to fail. The person feels more helpless, maybe thinking gets a bit disorganized. You might start seeing physical signs, a racing heart, perhaps talking faster, the clouds are getting darker, maybe a few drops of rain.
Things are getting worse.
Right. Phase 3 is a severe level of stress and anxiety. At this point, the anxiety becomes almost unbearable. Panic can set in, thinking gets really disordered. There's often an urgent need to escape the emotional discomfort. They might be highly emotional, mood swinging rapidly. And crucially, at this stage, the person may become a danger either to themselves or potentially to others. The storm is definitely brewing, winds picking up.
Okay, that sounds serious.
And then there's phase 4, an elevated phase of crisis. This is when the person is really no longer in control. Not of their emotions, their thoughts, or their behavior. They might be completely unresponsive to verbal interventions, just consumed by intense fear or anger or despair. This is the full-blown storm. It demands immediate, decisive action to ensure safety. The key insight here for you listening is to watch for those escalating signs. Not just the initial hints, but that progressive increase in anxiety, confusion, withdrawal, maybe even hostility. That progression tells you when intervention becomes critical.
That's incredibly important for recognizing the urgency. Okay, so once you've identified these signs, maybe seen this escalation, what's the systematic approach? How do you actually go about understanding what's happening and figuring out how to help someone in distress?
When someone's showing clear signs of distress, a structured approach is really crucial. Think of it less like a rigid checklist and more like a systematic way to gather all the necessary information and plan support effectively. It always begins with a thorough assessment.
Assessment, right. And a big part of that, I understand, is something called a mental status examination, or MSE. What exactly are you looking for during an MSE?
The MSE is essentially like taking a snapshot of someone's current mental state, right here, right now. We observe things like their level of consciousness. Are they fully alert? Or do they seem drowsy, confused, maybe even stuporous? Their appearance and general behavior, how are they groomed? Is it different from usual? Do they make eye contact? Do they seem unusually restless, agitated, or maybe very slowed down?
Okay, so basic observations first.
Yes. Then we look at their affect and mood. Affect is what you see on the outside, their emotional expression. Do they seem flat, showing no emotion, or overly dramatic, labile maybe? Mood is their deeper, pervasive emotional state that they report. Are they generally upbeat, euphemic, consistently sad, dysphoric, excessively happy, euphoric, or wildly fluctuating?
Affect is what you see, mood is what they feel.
Got it. Precisely. Then, thoughts and perceptions are vital. Are their thoughts clear, logical, connected, or are they jumping around, tangential, maybe incoherent? Do they hold any fixed false beliefs, delusions? Or are they experiencing hallucinations, seeing, hearing, feeling things that aren't objectively there? And most critically, we always assess for any thoughts of harming themselves, harming others, or any other violent intentions, gently but directly.
How do you ask about hallucinations without sounding like you think they're crazy?
That's a great point. We'd ask something neutral, like, are you hearing anything that others might not be hearing? Or what do you hear right now? Rather than implying their experience isn't real to them. We also look at their attitude and insight. How do they relate to you during the assessment? And crucially, how much do they understand about their own situation, their illness? Remember anosognosia. Someone might have absolutely no insight that they're ill, which significantly impacts how you approach them and plan care. And finally, we consider their basic cognitive abilities, things like attention span, memory, problem-solving skills. Can they follow a conversation? Remember simple instructions.
Okay, so the MSE gives us that objective snapshot of their current state.
Yeah.
But to get the full story, the subjective side, there's also the psychosocial assessment.
Yeah. Exactly. That's where we gather this subjective data, painting a much broader, more personal picture. It's about their story. We'd ask about their main concern, what brought them in their chief complaint, any history of self-harm or suicide attempts. Their medical history, current medications, any past psychiatric history, family dynamics, social support systems. Exposure to trauma is a really important one, and how they typically cope with stress, what usually works for them. We'd also consider their cultural background and developmental stage, as these profoundly influence how distress is experienced and expressed. And always, woven throughout this, is risk assessment, looking for immediate danger to self or others. And we need to ask about substance use history that can really impact their current state and treatment.
So it's a very comprehensive picture you're building.
It has to be. And beyond just talking and observing, we often use proven questionnaires or screening tools, like the Columbia Suicide Severity Rating Scale, CSSRS, to standardize suicide risk assessment, makes it more objective. And of course, laboratory and diagnostic tests are often needed to rule out any underlying medical conditions that might be causing or mimicking mental health symptoms, things like thyroid problems, infections, electrolyte imbalances, or to monitor medication levels.
That comprehensive assessment really highlights how complex this can be. So once you have that picture, how does it translate into a plan? Is that where identifying problems and setting goals comes in?
Yes, that's precisely the next step. From all that assessment data, we identify specific problem areas. In nursing, we might phrase these as nursing diagnoses like risk for suicide, ineffective coping, or disturbed thought processes. Then we move to outcome identification. This is about setting clear, measurable goals for improvement collaboratively with the individual if possible. We make these goals SMART, specific, measurable, attainable, relevant, and time-bound.
SMART goals, okay.
For example, a SMART outcome might be the individual will identify 2 new coping strategies by the end of the week, or the individual will remain free from self-harm during their hospital stay.
Right. Then we get to planning interventions. And I imagine safety is always the absolute top priority here.
Always. Number 1, planning intervention starts with safety. This often includes developing a crisis or safety plan with the person. This plan is crucial. It's like a collaborative roadmap, outlining their specific triggers, their preferred coping strategies, and key support resources, people they can call, places they can go. For anyone identified as being at risk of suicide, a critical planning step is an environmental risk assessment. That means systematically removing any potential lethal means from their immediate environment. And a really powerful framework guiding all intervention planning is trauma-informed care, or TIC.
Trauma-informed care. Tell me more about that.
TIC means recognizing that trauma is prevalent, and its effects can shape how people react to situations, especially stressful ones like seeking help. So it means prioritizing physical, psychological, and emotional safety above all else in every interaction. It's about promoting a sense of control and empowerment for the individual. Things like giving them anticipatory guidance, telling them what to expect before it happens, always asking permission before any physical touch, protecting their privacy rigorously, using clear, consistent messaging, offering choices whenever possible.
That sounds incredibly respectful and empowering. So once those interventions are planned, what does the implementation phase actually look like in practice? What are these interventions?
Well, they cover a wide range of support, guided by professional standards. First, there's coordination of care. This means connecting the individual to community resources, support groups, maybe outpatient therapy, case management, ensuring continuity of care. Then there's crucial health teaching and health promotion. This is about empowering them with knowledge, educating them about their condition, self-care strategies, stress management techniques, coping skills, and, very importantly, information about any prescribed medications, purpose, dosage, side effects.
Knowledge is power, right?
Yeah, absolutely. We also have pharmacological, biological, and integrative therapies. This primarily involves administering prescribed medications and carefully monitoring their effectiveness and any potential side effects. It could also include things like light therapy for seasonal depression, for example. Milieu therapy is another key area. This is all about creating and maintaining a safe, welcoming, structured, and supportive environment, the milieu. It involves things like managing stimuli, reducing noise or chaos if someone is overwhelmed, setting clear expectations and boundaries, and always advocating for the least restrictive environment possible, maximizing their freedom while ensuring safety.
So the environment itself is therapeutic.
Yes. And of course, a cornerstone is the therapeutic relationship and counseling. Building rapport and trust is fundamental. This involves using specific communication techniques, active listening, asking open-ended questions, validating feelings to help them explore their issues and develop problem-solving skills. If someone is experiencing severe anxiety or panic, the communication approach shifts. It needs to be very firm, short, simple statements delivered in a calm, slow, low-pitched voice. Helps to ground them when they feel overwhelmed.
That's a specific technique for a specific state. Makes sense.
It does. And finally, crisis intervention. If someone's agitation is escalating, the first approach is always verbal de-escalation. This involves specific techniques: maintaining a safe personal space, appearing calm and non-provocative yourself, establishing verbal contact using simple language, identifying and validating their feelings. I can see we're very upset right now. Active listening, setting clear, consistent limits on behavior, and offering choices and options whenever possible. If and only if verbal de-escalation is unsuccessful and there's an immediate danger of harm to self or others, then in certain settings, more restrictive measures like seclusion or physical restraints might become necessary.
But that's a last resort.
Absolutely, a last resort, used only when absolutely necessary for safety, following very strict protocols for the shortest possible duration, and with continuous monitoring and assessment.
Okay. And the beauty of this whole systematic approach, as you laid it out, is that it culminates in an evaluation, right? It's not a one-and-done thing.
Exactly. Evaluation is ongoing, continuously assessing the person's progress towards those SMART outcomes we set earlier. Are the interventions working? Do we need to adjust the plan? It's a dynamic process.
That systematic approach is clear. But you mentioned something else.
Yes. What's fascinating here is that beyond any system or process, there are these profound ethical and legal responsibilities that guide everything we do when we observe signs of distress. It's not just about what we can do technically, but what we should do ethically, and how we must protect the individual's fundamental rights.
Right. So what are those core ethical principles that guide this incredibly sensitive work?
Well, we operate under several fundamental ethical principles, often drawn from frameworks like the Nursing Code of Ethics. Beneficence is a key one. The principle of actively doing good, promoting well-being, preventing harm, and always advocating for the best evidence-based treatment for the individual. Then there's non-maleficence, the duty to do no harm. This means being incredibly careful, weighing potential risks against the benefits of any intervention. Minimizing harm is paramount. Justice is about fairness and equity, ensuring everyone receives quality care, regardless of their background, socioeconomic status, race, or anything else. It also involves actively working to address health disparities in mental health care access and outcomes. And fidelity. This speaks to our commitment to being trustworthy, keeping promises, maintaining competence, and providing reliable, evidence-based care, honoring the therapeutic relationship.
Beneficence, non-maleficence, justice, fidelity.
Yeah.
Got it. And what about the individual's rights? What absolutely must be protected, especially in mental health care where, let's face it, autonomy can sometimes be challenged?
Patient rights are absolutely paramount, and there are legal frameworks like the Patient Self-Determination Act that underscore these. Every person generally has the right to appropriate treatment in the least restrictive setting possible. We avoid unnecessary confinement or restraint. They have the right to an individualized treatment plan, developed collaboratively whenever feasible, the right to participate in their own care decisions, the right to receive clear, understandable explanations of their treatment, the risks, benefits, alternatives. This underpins informed consent.
Informed consent seems key.
It's crucial. Consent must be informed and voluntary before any treatment, with very specific, legally defined exceptions, usually only for immediate life-threatening emergencies or if there's a specific court order for treatment. They also have the right to freedom from restraint or seclusion, again, except in those clearly defined emergency situations to prevent imminent harm, the right to a humane treatment environment, the right to privacy and communication, access to their own medical records, and central to all of this is confidentiality. Rigorously protecting their private health information, their PHI, with very limited exceptions defined by law, like the duty to warn if there's a specific threat to another person.
That brings up a critical challenge, though. What happens with informed consent when a client, maybe due to their mental state, actually lacks the capacity to make those decisions for themselves?
That's a really important point. When an individual is assessed as lacking the capacity to consent, perhaps due to severe psychosis, delirium, or profound cognitive impairment, then substituted consent becomes necessary. This is typically obtained from a legally authorized representative, like someone with healthcare power of attorney, a court-appointed guardian, or sometimes next of kin, depending on specific state laws. The process of evaluating someone's capacity to make healthcare decisions is complex and usually involves healthcare professionals making that determination based on specific criteria. And related to responsibilities, we also have mandatory reporting duties in many situations.
Mandatory reporting.
Yes. Healthcare professionals are often legally required to report suspected abuse or neglect, whether it involves children or vulnerable adults, to the appropriate authorities, like Child Protective Services or Adult Protective Services, or sometimes law enforcement. Depending on the location, there might also be reporting requirements related to intimate partner violence, although this is often more complex regarding adult consent. And there's a serious professional and ethical responsibility to report a colleague if you have reasonable suspicion they have a substance use disorder that could be impairing their practice and potentially endangering clients. Client safety comes first.
Wow, that's a heavy responsibility. And tying all this together, it really seems to boil down to professional conduct, being acutely aware of our own biases, and maintaining those incredibly important professional boundaries.
Absolutely. It's fundamental. Recognizing how our own beliefs, values, or unconscious biases might influence the care we provide, and actively working to mitigate that, and maintaining clear professional boundaries is essential for a therapeutic relationship. This means things like limiting personal self-disclosure, avoiding dual relationships like personal or business relationships outside of the therapeutic context, even being cautious about social media contact. The therapeutic relationship itself, built on trust, respect, empathy, and those clear boundaries, is truly the foundation of effective client care and healing, especially in psychiatric settings.
Okay, let's try and unpack this even further. Let's look at some of those real-life situations you shared in the source materials to really see how all these pieces, the assessment, the interventions, the ethics, fit together in practice. This is where the rubber meets the road, right?
Yeah.
Seeing these principles actually applied.
Indeed. Let's start with sample case A. This was a 32-year-old male dealing with major depressive disorder, and importantly, with active suicidal ideation. The immediate observable signs were that profound sadness in his affect, a deep sense of hopelessness he expressed, an actual stated desire to die, and also clear neglect of his personal hygiene. This immediately flagged risk for suicide as the top priority nursing diagnosis.
So safety first.
Safety absolutely first. The immediate strategies implemented were direct screening for suicide risk using a tool like the CSSRS, providing constant one-on-one supervision, a sitter, removing any personal belongings that could potentially be used for self-harm, conducting a thorough environmental scan of his room to secure the space, trying to establish a no-harm contract, although the effectiveness of those is sometimes debated. It's about opening communication, and of course, administering prescribed antidepressant medication. The key here was rapid, structured intervention focused squarely on preventing harm.
Okay, that makes sense for immediate risk. What about Kay, the 27-year-old with borderline personality disorder?
Yeah. Kay's case presented different, though equally serious challenges. Her key symptoms identified were recurrent self-injury, yes, suicidal behaviors too, but also those extreme and rapid mood shifts. Impulsive actions like promiscuity were mentioned, intense fears of abandonment, highly unstable interpersonal relationships often marked by anger or sarcasm. For Kay, the proposed strategies focused heavily on establishing clear structure and boundaries right from the moment of admission.
Structure and boundaries seem key for BPD.
Very often, yes. This meant clearly explaining hospital policies, rules, and the consequences for breaking them, carefully searching her belongings for potential self-harm items, implementing rigorous suicide precautions due to her history, and, crucially, consistently setting firm but fair boundaries and limits on manipulative or acting out behaviors. The plan would also ideally involve specialized psychotherapies proven effective for BPD, like cognitive behavioral therapy, CBT, or perhaps even more specifically, dialectical behavior therapy, DBT, which directly targets emotional dysregulation and interpersonal difficulties.
Right, specialized therapy makes sense. Then there was Dana. Her situation was complex, a serious medical issue, DKA, but also trauma from intimate partner violence.
Yes, Dana's case was a powerful example of integrating medical and psychosocial care, especially using trauma-informed care, TT principles. Her distress was evident, anxiety, agitation, nonverbal cues suggesting trauma, even though she was there for a medical emergency. The team applied TEEP beautifully. They started by simply asking Dana what she needed to feel safe in that environment. That's huge.
Giving her control back.
Exactly. Based on her response, they moved her to a quieter room. They actively worked to protect her privacy, gained her specific consent regarding anonymity. They provided anticipatory guidance explaining procedures before they happened. They consistently asked permission before any physical touch, which is critical for trauma survivors. And they offered her choices for anxiety-reducing techniques like deep breathing or distraction. Her discharge planning wasn't just about managing the DKA. It focused heavily on finding safe housing options and connecting her with comprehensive wraparound support services for survivors of violence.
That's a really holistic approach. And briefly, Jessica, the case involving substance use disorder.
Jessica's case really reinforced the need for integrated treatment, It highlighted identifying the specific criteria for an SUD, understanding its impact, but also developing treatment plans that address co-occurring medical problems, which are very common with SUDs. And critically, building robust social supports involving family where appropriate, connecting with recovery groups like AA or NA is often essential for long-term recovery. These cases, taken together, really show how you move from recognizing distress to applying a systematic, ethical, and deeply empathetic approach to actually try and help.
They really do. These real-world examples bring all the theory, the systematic approaches vividly to life. They show us how recognizing, assessing, and intervening with mental distress isn't just about following steps on a flowchart. It's about human connection, careful observation, and informed, compassionate action.
It really illustrates the immense complexity and, yes, the nuance of mental health. There are no easy answers sometimes. But it also shows the profound empowerment that comes from having a structured yet empathetic approach, knowing what to look for, how to ask, how to respond effectively. It's about being present and having the tools to help.
So, wrapping this up, what does all this mean for you listening right now? This deep dive, hopefully, provides a powerful framework for understanding. But maybe more than that, it's an invitation for continued observation, for empathy in your own life with the people around you. Perhaps the most profound insight from our deep dive today is recognizing that true well-being isn't simply the absence of distress. It's really about the active, informed presence of support, of understanding, and maybe finding the courage to look for and acknowledge what's often unseen.